I guess we'll begin. The workshop that you are attending, if you're in this room, is the Mediastinum, Anatomy, Pathology, and Imaging Evaluation. Objectives, we'll begin by, of course, reviewing normal anatomy. We'll introduce the divisions of the mediastinum, understanding their applications, and importantly, the limitations of this rather arbitrary divisional technique. We'll review the radiographic signs of mediastinal disease, review pathology that can occur in the mediastinum, and we'll integrate in our evaluation of mediastinal processes, cross-sectional imaging, and off-axial imaging, including CT and MR. When we talk about the mediastinum, traditionally, we talk about the anterior, middle, and posterior division of the mediastinum, and this is based on delineations based on anatomy as perceived on a lateral chest radiograph. So, for instance, a typical and widely used approach would be to define the anterior mediastinum as that zone which anteriorly is defined by the posterior aspect of the sternum and posteriorly defined by the anterior part of the heart and the ascending aorta up to the great vessels. The posterior, the middle mediastinum then extends from that point to a point delineated by the posterior aspect of the heart in a line a centimeter in front of the vertebral bodies, and all beyond that would be therefore the posterior mediastinum. Other divisions, other methodologies are in use, including defining the anterior aspect of the posterior mediastinum by a line 1 centimeter posterior to the anterior aspect of the vertebral bodies, and so on. The point is that there isn't, in fact, uniform application of the divisions of the mediastinum. And furthermore, I want to stress, because it's my own personal bias, that these are based on rather arbitrary anatomic landmarks on the lateral chest radiograph. When we talk about the anterior mediastinum, and I am going to use for the purposes of the discussion right now the first more commonly used divisions, the anterior mediastinum would include normal structures such as the thymus, anterior mediastinal fat, lymph nodes, and the brachiocephalic vessels. So it's this area here, obviously anterior to the vessels. The middle mediastinum, therefore, would include the heart and the great vessels, and additionally lymph nodes, all the vessels going in and out of the mediastinum, the trachea, and the main stem bronchi, and the nerves, including in particular the upper extent of the vagus nerve and the phrenic nerve. The posterior mediastinum would include the whole paravertebral region, including the descending aorta and its branch vessels, the esophagus, lymph nodes, the thoracic duct, nerves, including the lower aspect of the vagus nerve and the paravertebral areas bilaterally. And we tend to forget that this is part of the posterior mediastinum. Now, just to shake things up a little bit, and because I'm a bit of an iconoclast, I'd like to maybe question whether this system is really as useful as we were all taught it was back in the days when radiographic imaging relied on plain film radiography. Because I feel I should be fair, when there is an iconoclastic slide, I'll border it in green. And otherwise, purple background slides are the traditional dogma. And if you're that kind of a person, you can stick with those. So the chest X-ray divisions of the mediastinum, are they truly useful? Obviously, I've revealed my bias a little bit. Yes, they can generate a limited, or help you to generate a somewhat limited differential diagnosis if there's a pathologic process. Yes, you can order the differential on the statistical likelihood of a mass occurring within a specific compartment based on this kind of a technique. And does it dictate the next test ordered? Well, I think that is really a moot point, because in fact, if you suspect a mediastinal mass on a chest X-ray, whether it's a middle or a posterior or an anterior mediastinal mass, no matter where you are in this morass, the fact is the next test ordered in almost all cases is a contrast-enhanced CT. Now, there is a little bit of, there are some disclaimers there, but for the most part, once you suspect a mass on radiography, you're going to get a contrast-enhanced CT. So we're going to carry this further. Is it, in fact, not useful? Are these compartments based on true anatomic compartments? Well, no, they're not. Are they divided by fascial planes? No, they're not. Do anatomic structures stay where they belong? No, they don't. Because if they did, words like tortuous and ectopic would not be incorporated as frequently as they are in our radiography reports. Additionally, pathology displaces normal anatomy. Pathology crosses these arbitrary divisions, and the same pathology can occur in several of these divisions. Finally, as we've pointed out, there isn't uniformity in the systems as applied. So based on all of this, we really do have to question whether this is useful. Examples, if the heart is in the middle mediastinum, such as it's supposed to be, then where is this thymoma? Is it in the middle mediastinum? It's supposed to be in the anterior mediastinum. The esophagus is in the posterior mediastinum, right? Well, actually, it looks like it's in the middle mediastinum in this one. And in fact, when there's a pathology, such as in this patient with gross thickening of the esophagus due to esophageal cancer, we've got extension of disease in this, to the subcarinal region, which is clearly in the middle mediastinum. And then finally, pathology crosses these arbitrary boundaries, and that's true. This is a small cell cancer which is spread throughout all three compartments. So to further my questioning, and note again the green bordered iconoclastic slide, to further question whether this system is useful, I want to point out that there's a lot of overlap in pathology. The overlapping disease processes are in yellow, and in the middle mediastinum, the most common cause of a middle mediastinal mass is adenopathy, whereas in the posterior mediastinum it's a neurogenic tumor. But nonetheless, adenopathy, vascular lesions, neurogenic tumors, thyroid lesions, and bronchogenic cysts can occur in both the middle and posterior mediastinum. So based on the overlap in pathology, again, one has to question whether these divisions are useful. Okay, having shaken up your world a little bit, we'll go through a couple of radiographic signs. The azigoesophageal stripe sign, you should have a tongue of lung infiltrating in here, and you should be able to see the posterior aspect of the posterior inferior aspect of the intermediate bronchus and the middle mediastinum. This is the little bit of lung, so you're looking at this interface right here. When you have a pathologic process in the azigoesophageal recess, you're going to have soft tissue bulging into this area. This is the azigoesophageal stripe right there, and in this case, this soft tissue is due to this very large hiatal hernia. Not particularly exciting pathology, but nonetheless a middle mediastinal process causing this abnormal sign. This is an example of what at first glance might appear to be a parahilar mass, but in fact you can see the pulmonary artery. Here's the right interlobar artery through the mass. This is a hilar overlay sign, and this mass is therefore, based even on this frontal film, clearly either anterior or posterior to the hilum, but not a mass of the hilum. And in fact, this turned out to be a posterior mediastinal mass due to extramedullary hematopoiesis, which we see exuberant extramedullary hematopoiesis here, and symmetric changes at a slightly lower level. The cervicothoracic sign is helpful in deciding whether or not a mass is anterior or posterior, and the reason being, number one, if you have a mass in the upper portion of the mediastinum at the cervicothoracic junction delineated by air, you're going to have a very clean, sharp border of the mass with the lung, such as would occur posteriorly. If there's a hazy border, such as we're seeing here, this is going to be an anterior mediastinal mass. Well, that is certainly suggested by the fact that the trachea is deviated to the right. But we can see here this anterior mediastinal mass, and the reason for its haziness is that the lung at this level is way down here. We don't have a delineation of aerated tissue against this soft tissue, whereas in this neurogenic tumor, posteriorly, we have this sharp margin due to its interface with an aerated lung. This is the cervicothoracic sign, and it can help you in localizing as anterior-posterior a mass in the cervicothoracic junction. Similar thought process applies to the thoracoabdominal sign. If you have a mass which has a sharp margin as it extends below the dome of the diaphragm, you can surmise that this is posterior, where the costophrenic angle extends inferiorly in the back of the hemithorax, and this is a neurogenic tumor posteriorly. So how do we work up mediastinal masses? As I said, the first test in almost all cases is a multi-detector CT. It's a CT study with contrast, and these certainly, if you're using a multi-detector CT, should be performed as such with thin sections on the order of 1 to 2 millimeters. The reason being, you can anticipate that you're probably going to be creating MPRs, multiplanar reformatted images, for pre-surgical planning, to assess vascular supply, and so forth. So thinner sections are going to be useful. Bolus tracking software, as was discussed this morning, is very useful to optimize aortic and branch vessel enhancement. We use 130 Hounsfield units as our threshold for triggering the scans. You should consider a pre-contrast study in certain cases, but for the most part, we need contrast in almost all cases. Here's an example of MPRs created with 1.25 millimeter thick sections. They're somewhat, there's some stair-step artifact, but for the most part, you get a very good delineation of the relationship of this thymic mass in the substernal region to the heart and the great vessels and so forth. MR and CT PET, when are they useful? Certainly, as I said, most of the time we're going to use intravenous contrast, and if there's a contraindication to intravenous contrast, then you may want to consider MR as your first-line examination. Alternatively, some people would argue that if you truly think that you might be looking at a neurogenic tumor, i.e., in contradistinction to the philosophy that I've been espousing up until now, if it's in the posterior mediastinum and you've localized it as such and you feel there's a high likelihood it's going to be a neurogenic tumor, you might go directly to MR studies in those cases. Lack of enhancement if there's lack of enhancement of a lesion on CT, but you aren't getting densitometry measurements that are entirely consistent with fluid, but you want to prove that it's a cystic lesion, i.e. a complicated cyst or a bronchogenic cyst with proteinaceous or bloody material in it or so forth, an MR can be useful to prove the cystic nature of an otherwise complex lesion. PET-CT is obviously useful, as we've heard this afternoon, for staging of neoplasms and to assess response to therapy or the problematic scenario of recurrent disease. Sometimes this can be useful to differentiate inflammatory from non-inflammatory conditions, as well as outside the realm of malignancy. Many of the cross-complicating processes in malignancy, however, including infection and radiation changes, as we saw, are going to be PET positive, so it may still be a bit problematic. Okay, so we will, after having gone through all of that, we will in fact move through the mediastinum according to the anterior, middle, and posterior divisions. Now, the laundry list of things that can occur in the anterior mediastinum is quite long, including lymphomas and thymomas and all of these things that we know and you can read. But in fact, many of them are quite unusual: thymic carcinoids, thymolipomas, thymic cysts. And in fact, the truth is the 4 T's that we all learned as residents pretty much, if you expand a little bit on them, cover quite a few of the processes. So thymomas and other thymic processes, teratomas, including germ cell neoplasms, lymphomas, terrible lymphomas, and other causes of lymph nodes, intrathoracic thyroid, and as a little bit of an addition outside of the realm of T's, hernias in the cardiophrenic angles. When we're considering the thymus, before you can diagnose a mass, you have to have a fairly good understanding of the range of normal appearances and sizes for the thymus, and that would also require an understanding of how the thymus changes through as we progress through our various ages in life. Most of the time, the thymus is an arrow-shaped structure, such as we see here, occurring in upwards of 60% of cases. It's not unusual, however, to have involution or absence of the isthmus of the thymus, so you in fact have 2 separate lobes, but they usually still assume a somewhat triangular shape, or they have an orientation to each other as something of a triangle. Occasionally, you'll have visualization of one or the other lobe, but they should not, in fact, appear as a mass. Thymomas are the most common cause of an anterior mediastinal mass. We see a soft tissue, fairly homogeneous mass here adjacent to the right heart border. They are comprised of thymic epithelium. They're generally solitary in soft tissue and density, although they may have calcifications and they may have cystic areas. Those aren't common, and most of the time it's a homogeneous, quite characteristic-looking lesion. They are associated, as we all know, with myasthenia gravis, occurring in about 15% of cases. 75, far more common disease associated with myasthenia gravis is thymic hyperplasia, not thymomas. They're also associated with hypogammaglobulinemia and pure red cell aplasia. About a third of thymomas are what used to be called malignant, and now we're calling invasive. This is in fact, a true malignancy with a more aggressive course. These can be hard to diagnose, however. They too are comprised of thymic epithelium. They are locally invasive, and when they metastasize, the most typical appearance is that of drop metastases along the fascial planes and along the pleural surfaces. Rarely you can have a large chest wall mass. CT, in fact, is quite unreliable for assessing invasion, an invasive thymoma, if it's well encapsulated. If you see an infiltrating mass in the anterior mediastinum, then you can be pretty sure it's an invasive thymoma. But the absence of detectable invasion, unfortunately, doesn't rule out the possibility that's an invasive thymoma. Hence, surgical resection is indicated. Findings which are suggestive of invasive thymoma, if appreciated on CT, would include focal or diffuse pleural thickening, the drop mets that I just discussed, encasement of mediastinal vessels, obliteration of normal fat planes, pericardial thickening, or an irregular interface with the lung. So here we have an anterior mediastinal mass. We can see part of it here, and we can see an abnormality in the mediastinal contour here. And as well, we see a soft tissue mass at the lung pleural interface in the lower right hemithorax. Posteriorly, we can appreciate that mass. And on the lateral film, we can appreciate this large, somewhat lobulated soft tissue mass in the anterior mediastinum. So at CT, again, we see this lobulated anterior mediastinal mass, obliteration of the fat planes between it and the ascending aorta and the pulmonary outflow tract, lobulation here. Looks like a little bit of invasion of the mass into the internal mammary region. And we see at CT, on the right inferiorly, this soft tissue mass consistent or representing the soft tissue mass we saw on the radiographs. This is the drop metastasis in this invasive thymoma. Lung window here shows that this is actually vaginating into the lung as well. Thymic carcinoma. On CT, this is generally a well-differentiated carcinoma. It'll mimic that of a thymoma, but they can become very bulky and invasive, and there may be metastases. The prognosis of these carcinomas depends very much on the histologic grade. When they get bigger and bulkier, the likelihood of malignancy worsens. This one has dystrophic calcifications, and you can see their metastases in the cervicothoracic supraclavicular lymph nodes. So in the spectrum of thymic epithelial tumors, we basically move from the non-invasive thymomas to the invasive thymomas to true thymic carcinomas. And the larger size, the higher the predilection, the larger size, the more aggressive pathology, the more likelihood for morphologically invasive recognizable disease and a much poorer prognosis, whereas the paraneoplastic syndromes, in fact, are going to be more common in the better differentiated but less aggressive tumors. Recognizing that the thymus is largest in childhood and during your adolescent years and then regresses with complete involution, you need to take into consideration the age of the patient when deciding whether or not the thymus is enlarged or whether in fact not you have hyperplasia or a thymic mass. In a teenager less than 20 years of age, the limb of each of the thymic limbs should be less than 1.8 centimeters in diameter. By the time you're older than 20, they should be less than 1.3 centimeters in diameter, and you should start to have a nice convex border to the gland. So we have the soft tissue here, we have fat between the thymus and the vascular structures, and this nice convex border. And by the time you're over 40, you really shouldn't have a discrete recognizable thymus anymore. You should just have fatty involution with maybe a little bit of stranding, but really no nodules and no soft tissue. Thymic hyperplasia represents an enlarged hyperactive thymus. The anatomy, the gross architectural and histology is normal. It's just hyperfunctioning. Causes You can see thymic hyperplasia as a rebound response post-chemotherapy, but also after resolution of high cortisol level conditions. And these can be iatrogenic, such as in a patient who's being treated with high-dose steroids, but they also may be intrinsic, for instance, in patients in a high stress, with high stress levels, or Cushing's syndrome. Hyperthyroidism, Graves' disease, is another cause for thymic hyperplasia, and thymoma. Here's a patient with Graves' disease. Before her Graves' disease was treated, we see soft tissue in the anterior mediastinum. Now, if this patient were 15, I wouldn't be concerned about this in the least. The problem is this is a 45-year-old. This is way too much thymic tissue for a 45-year-old, and you look around at this point for causes of thymic hyperplasia. Note that there is no mass, there's no discrete nodule. Rather, it is a well-formed, symmetric, bilobed arrowhead, thank you, arrowhead-shaped structure. Good cause for this is Graves' disease. The Graves' disease is treated, and 2 years later we have involution, fatty involution of the gland, as would be typical for a patient of this age. Moving now to the germ cell neoplasms. These are histologically identical to testicular and ovarian carcinomas. The types are teratomas, probably the most common, seen in 70% of cases, but also germinomas and seminomas, and then the much more rare and aggressive lesions, including embryonal cell choriocarcinoma, and yolk sac tumors, or endodermal tumors. The germ cell neoplasms, beginning with the teratoma, these are derived from more than one of the 3 germ cell layers, the endoderm, the ectoderm, and the mesoderm. When they're mature, they're large cystic masses. Typically, they have representative tissue from these different germ cell layers. So quite commonly, we'll see areas of fat. Here we have a region of interest densitometry, measurement of -7. Here we have a measurement that's 12, so we've got fluid and fat in this large teratoma. Here's another patient with a typical very large teratoma with dystrophic calcifications, areas of fat, areas of fluid, areas of soft tissue. Seminomas, on the other hand, tend to be very homogeneous, soft tissue density, large, again, large masses. They may have mass effect on mediastinal structures, but they generally don't have the heterogeneity of tissue we would see in the teratomas. Hodgkin's disease. Very common presentation of Hodgkin's disease is a large anterior mediastinal mass. In fact, this is probably a confluence of enlarged lymph nodes. 85% of Hodgkin's patients present with thoracic disease. The middle and posterior mediastinum are less frequently involved, but it's not unusual to have involvement there. Generally, Hodgkin's lymphoma is going to be a homogeneous mass. However, it can be cystic. And remember that after treatment, there may be marginal regression of the mass, but you may have dystrophic dense calcifications within the mass. Frequently, as I just said, there's residual lymph node enlargement even after the disease has been sterilized. So here we have a typical presentation of a Hodgkin's lymphoma with the predominant mass, the dominant area of adenopathy being in the anterior mediastinum. And you can see that at the margins of this, there are in fact discrete lymph nodes forming kind of a homogeneous mass, which is extending into the parasternal region here. Note that there are, in fact, prevascular and perivascular lymph nodes, so there is middle mediastinal involvement in this case. Again, predominant mass, however, localized to the anterior mediastinum, as is typical. These can occasionally have cystic lymph nodes, as I said, and as a reminder, as mentioned, bulky nodes remaining post-treatment, even after being treated, will oftentimes develop coarse, chunky dystrophic calcifications. So you'll end up with oftentimes visible on radiography, densely calcified anterior mediastinal nodes. Thyroid masses. This is the primary thoracic inlet mass seen in adults. A big thyroid can in fact extend into the anterior, middle, or posterior mediastinum, so you've got to keep it on your differential for an upper mediastinal mass. In fact, the extension into the middle mediastinum is most common. The differential diagnosis includes other, basically all causes of thyroid masses, including adenomas and neoplasms. The trick is to document continuity with the thyroid gland, the normal gland that should be in the thyroid bed, because in fact, ectopic thyroids are quite rare. They're generally heterogeneous with calcifications and cysts, and they will be of high density even prior to the administration of intravenous contrast because of their inherent high iodine content. After administration of intravenous contrast, there's intense prolonged enhancement. Nuclear medicine radioiodine scans can be confirmatory if there's any question about whether or not you're truly looking at an intrathoracic goiter. This is generally fairly straightforward. Here's a scanogram from this CT showing a large upper mediastinal mass displacing the trachea to the right, in fact, probably deforming the trachea a little bit. And corresponding CT shows right lobe and a grossly enlarged left lobe, pushing the trachea to the right, a little dystrophic calcification here, a couple of low-density foci here. And if there's any question, as I said, the trick is to just trace it back and connect this to the thyroid gland. Ectopic thyroid tissue, as I said, is quite unusual, but in fact it happens. Here's a patient, I'm showing you the image from the neck to reassure you that in fact the normal thyroid tissue on the right is where it should be. There's scant tissue on the left. As we move down, there's no connection or extension of this tissue into the mediastinum. This mass, therefore, was perplexing and was thought to probably be a thymic mass, a thymoma, but in fact this proved at surgery to truly be an ectopic thyroid, which is unusual but does happen. So I don't know what the teaching point here is after telling you it's going to be a thymic mass. Occasionally ectopic thyroids happen. Morgagni hernias. These represent 1 to 5% of congenital hernias. Generally, they're easily recognizable on CT, although they can be perplexing on radiography unless there's herniation of air-filled bowel loops, in which case they're pretty straightforward. What these are is a herniation of fat, liver, bowel through the anterior diaphragmatic slips, in general next to the heart. They're generally on the right in the cardiophrenic angle anteromedially. Visualization of vessels on CT is very characteristic. So in this particular case, this right pericardiac mass isn't much of a diagnostic dilemma because we're aided by the presence of air in the herniated bowel loops. Would that something other than air-filled bowel loop had herniated, you would be a little bit challenged to, based on this radiograph, diagnose specifically what this represents. Corresponding CT in this patient shows, number one, the very characteristic branching vessels, contrast enhanced in this case, omental vessels as they come streaming through this diaphragmatic slip. And we see a lot of herniated omental fat, and here's the nice gas-filled bowel loop. Here's another gas-filled bowel loop. So this, based on these two imaging findings, really isn't much of a dilemma. I'm not going to spend a lot of time talking about vascular disease and aortic disease, but just as a reminder, there's a lot of vessels in the anterior mediastinum, and any pathology of the aorta, in this case, we're looking on a non-contrast and a contrast-enhanced study of a large pseudoaneurysm. Vascular structures are another cause of anterior mediastinal masses. Middle mediastinum. Again, a rather long list. Adenopathy in the middle mediastinum is the most common cause. Vascular pathology, remember we've got the arch and all the veins and all the great vessels moving in and out of the thorax in the middle mediastinum. Airway pathology, anything to do with the heart and the pericardium. Foregut malformations and bronchogenic cysts, congenital developmental anomalies. Thyroid masses, again, that's going to keep cropping up on all of these lists. Neurogenic tumors, parathyroid masses are all included in the spectrum of processes in the middle mediastinum. When we talk about adenopathy, basically you can break down the etiologic processes simply by saying, well, they're going to be neoplastic, inflammatory, or infectious. Confluent masses very commonly are due to bronchogenic carcinomas, squamous and small cell cancers, of course, being the most typical for large central masses like this, but lymphoma and some metastatic processes, including in particular seminomas, can present as large mediastinal masses. Discrete nodes will be seen again in lymphoma and some metastatic processes. Differential points when assessing mediastinal adenopathy, low density nodes. Typically, this is going to happen with infections, and notoriously mycobacterial infections, including TB and Mycobacterium avium complex disease, can give you low density necrotic nodes, but fungal infections can do the same. Any necrotic tumor can also give you a low density node. Remember that in tuberculosis, particularly in the setting of AIDS, but also outside of the setting of AIDS, post-administration of intravenous contrast, you may appreciate a briskly enhancing rim surrounding the low-density area. Enhancing nodes. Castleman's disease, we're going to talk about that in a minute. Metastases, in particular renal, thyroid, and small cell cancers can enhance tuberculosis. I guess I just talked about that, didn't I? The rim enhancement. And sarcoid rarely can enhance. Calcified nodes, again, granulomatous infections, tuberculous and fungal infections. Post-treatment Hodgkin's, we've already discussed. Sarcoidosis and silicosis, of course, are well-known causes of calcified lymph nodes. So enhancing nodes, again, I'll talk about Castleman's in a minute, but this is one of the causes for the most bright and impressive enhancement of lymph nodes. Low-density nodes. This is an AIDS patient, and we see this necrotic retrocaval paratracheal node with this rim of enhancement around it. There's a lot of lung disease here, too. But this pattern, rim enhancement, is typical of tuberculosis in AIDS. Symmetric hilar nodes with mediastinal nodes, paratracheal or subcarinal nodes is very typical of sarcoid. And also with sarcoid, typically we get these beautiful eggshell calcifications. We see them here, we see them here, we see them sometimes here. And better so, we see them as curvilinear, primarily peripheral calcifications around the subcarinal and hilar nodes in this patient with sarcoid. So Castleman's disease, I've alluded to this twice already. This alternative term, which nobody uses because Castleman's is easier to remember, is giant benign lymph node hyperplasia. So in this patient, this was an incidental finding. I frankly can't remember why she got this radiograph, but we see a soft tissue mass in the right paratracheal region, and on the lateral we can see it here. The trachea looks like it's in the normal place. And on CT, after administration of intravenous contrast, she was quite young, hence the appearance of her thyroid. I think she was about, her thymus, I think she was about 20. We see on the contrast-enhanced CT this large enhancing mass within which there's a low-density focus. And the level of enhancement, if you compare it, for instance, to the muscles, is brighter than the muscles, not quite to the level of the contrast-enhanced vessels, but nonetheless brightly and briskly enhancing. She also had dystrophic calcifications in this mass. This is a disease, as I said, is oftentimes an incidental finding in a young asymptomatic patient. It's generally unifocal adenopathy. And 90% of the time, the pathology is the hyaline vascular type, and it's not associated with symptoms, hence it's often picked up incidentally. 10% of cases, however, are the plasma cell type, and these are the type which are, in fact, associated with constitutional symptoms such as night sweats, fevers, hypergammaglobulinemia. This is the bad actor because this is the type that can transform into lymphoma. And this is the type that's also oftentimes multifocal. So this is the histology that you don't want to have. Intense enhancement, necrosis calcifications we've talked about. And because of the risk of lymphoma, lymphomatous transformation in this small subset, the treatment is surgical. So these are generally going to come out one way or another. Confluent masses, talked about this a little bit. Lung cancer, small cell and squamous cell in particular, are most typical for these large confluent central masses, in this case associated with adenopathy. But you can see how this has infiltrated the mediastinum, how it's encased the vessels. In fact, it's stretching and attenuating and narrowing the pulmonary arteries, which are being pulled and stretched and narrowed as they're encased by this small cell cancer. Lymphoma and metastatic disease are other causes for these large central masses. Bronchogenic cysts. This is a developmental abnormality of the primitive foregut. 75% of these occur in the mediastinum, but I have to keep reminding myself that 25%, which isn't that small a number, actually occur in the lung. As I mentioned, these can occur in all three mediastinal divisions, but the middle mediastinum is the most common. The lining, this is a true cyst, so the lining is of epithelium, in this case respiratory epithelium, whereas the wall of this cyst has cartilage, smooth muscle, and mucus glands within it. Because of the mucus glands, you can have variable amount of proteinaceous material in these glands, in these cysts. Generally, patients are asymptomatic, but when symptoms occur, they can be due to mass effect, because sometimes these can become very large. They're often very small, but sometimes they're large. They can also get infected, which can cause symptoms, and they may decompress either into the pleural space or into the airways. And we've had patients with these decompress into the airways, in which case they're coughing up the contents. Imaging features. The number one site in the middle mediastinum is the subcarinal region, with the right paratracheal region being the second most common. They're round or oval in shape and generally very well circumscribed. They're thin-walled, particularly if they're not infected. Calcifications are rare, but occasionally happen. On CT, they're generally fluid density, low density, but you may or may not get pure, nice single-digit water readings, because as I said, they can be complicated by proteinaceous material, a little grummacy stuff, a little blood, a little who knows what. And so you may get readings that are, up in the 20s or even north of the 20s. The soft tissue density, protein, mucus, milk of calcium, blood, as I said, can cause these densitometry readings to be higher than pure water. In this setting, well, we'll start with the fluid density. So if you get nice, clear, low-density central fluid, the MR characteristics are going to be quite as expected, with low signal on T1 and bright signal on T2 weighting. If you have more complicated fluid, however, both of these may demonstrate high signal on MR. So here's a typical bronchogenic cyst in a typical location, the most common location, in fact. We have a relatively large, homogeneous, low-density structure in the subcarinal region. It's displacing the heart a little tiny bit. Densitometry measurements are around 19 Hounsfield units. This is quite typical. Second most common site, as I said, is the paratracheal region. So here we can see a soft tissue mass not displacing the trachea. On the frontal film, on the lateral film, we can appreciate the same mass, partially overlapping, but not having any particular mass effect on the trachea. And on CT, we can see that it is a nice homogeneous, there's a little bit of streak artifact, but it's a homogeneous fluid collection, low density, low Hounsfield unit readings, and this is another bronchogenic cyst. They can be quite small sometimes, such as we're seeing here. This one is in the perivascular space. Sometimes these occur right behind the heart, and they can be confused with a small pericardial collection associated with the superior pericardial recess behind the aorta. But in fact, if you look carefully, they don't hook up with the pericardium. This one's reading 11 Hounsfield units, very typical. But they can be hyperdense. This is a non-contrast examination, and here we have a bronchogenic cyst, which is hyperdense due to the milk of calcium within the cyst. And as we mentioned, these are bright with T2 weighting on MR, no matter what's in them. Pericardial masses. The spectrum of pericardial masses would include a pericardial lipoma, pericardial fat pads, which can get quite large in Cushing's disease, Cushing's syndrome, or steroids. Pericardial cysts are very common. These are attached to the parietal pericardium, and they're lined by mesothelial cells, but they may not necessarily be in continuity with the pericardial space. Generally, these are asymptomatic masses occurring over the age of 30. So here's a typical pericardial cyst. In this case, we see the pericardium does in fact have a small amount of fluid, and it looks like it's in continuity with the pericardial space, but in fact there is no communication most of the time with the pericardial space. The right costophrenic angle region is the most common. Fluid density at CT, such as we're seeing here, is typical, with again low signal with T2 weighting, bright signal with, low signal with T1 weighting, bright signal with T2 weighting being typical MR characteristics. Vascular lesions in the middle mediastinum. Well, this is, I can't, talking about the aorta is a talk unto itself, so I'm certainly not going to do that. But anything going on with the aorta, such as acquired disease, an aortic arch aneurysm or a pseudoaneurysm, a dissection or a penetrating ulcer, hematoma, I'll show you briefly examples of that. But also, any of those things enlarging the aorta or causing para-aortic collections of any type can be a cause of middle mediastinal masses, as can aortic anomalies, such as arch anomalies, right and double aortic arches, left-sided superior vena cavas, aberrant right subclavian arteries, azygous continuation of the inferior vena cava, and so forth. Vascular anomalies, this is quite straightforward. This is a patient who clearly has a right aortic arch. Most of the time, there's going to be an aberrant left subclavian artery arising from this right arch. If there's true mirror image branching, 98% of these cases, almost all of them will have congenital heart disease, and they're generally going to be presenting much earlier in life. The trachea will be deviated to the left, just as it normally would be deviated slightly to the right by a left arch. So here we have a right-sided aortic arch, a little bit of atherosclerotic disease, a little bit of deviation to the trachea to the left, not generally a diagnostic dilemma. Double aortic arches, such as we're seeing here, are a little bit more rare, and these, in fact, represent a true vascular ring around both the trachea and the esophagus. So you can, in fact, have symptoms, particularly esophageal symptoms, due to compression. Generally, the right arch is larger than the left in these cases, although I would argue that that's not the case here. Acquired aortic disease, aortic aneurysms or aneurysmal ectasia of the ectasia of the aorta, such as we're seeing here, can sometimes be mistaken for a mass. In this case, the aorta is so beautifully unwound, we can appreciate that this density is due to this unwound ectatic aorta, which is slightly dilated. Aortic aneurysms can be fusiform or saccular, and if they have peripheral calcification, it can help you out. Aortic dissections, we're not going to spend a lot of time here, but you can, post-contrast, of course, identify the intimal flap and decide whether you're looking at a type A or type B dissection. You can identify the true versus the false lumen, interrogate and confirm patency and the integrity of the branch vessels, and look for the presence of pleural effusions and so on and so forth. But this can cause enlargement of the aorta in the middle mediastinum. So here we see a beautiful intimal flap, and we can do the MPRs and follow it down and so forth. Intramural hematomas can occur either due to a penetrating atheromatous ulcer going into the aortic wall causing bleeding, or spontaneous bleeding into the wall, or bleeding from the vasa vasorum into the media of the aortic wall. Once you have blood in the wall of the aorta, it's going to cause obviously thickening and enlargement of the aorta. It's going to be high attenuation. On pre-contrast CT, which is one of the reasons people argue to get the pre-contrast CT, if it's acute, it's going to be bright on both T1 and T2 weighted MRs. The treatment is controversial. Basically, people follow the same algorithm as that of aortic dissections, i.e. if it's restricted to the arch and descending aorta, they generally won't treat, whereas if there's ascending aorta involvement, they generally will. Certainly if there's aortic root involvement, they will. And here we see, again, intramural hematoma. Penetrating atheromatous ulcer, the history of this is basically you get atherosclerotic plaque, which becomes ulcerated. Substernal thyroids, I'm not going to spend much time here, but just again remind you that these are the crossover lesions, neurogenic tumors, and wandering esophageal lesions can occur in the middle mediastinum. Good, so we at least made it to the posterior mediastinum. Neurogenic tumors, number one, adenopathy, aortic disease, esophagus. You know what, we'll just work through it, I won't read the mass. Neurogenic tumors are the most common posterior mediastinal mass. Most of these, 70%, are benign. MR can demonstrate whether there's intraspinal involvement. In fact, this is the one instance where you might go straight to MR. They can occur related to the peripheral nerves, the sympathetic chain, and the paraganglia. They're generally slightly increased with T1 weighting and quite bright with T2 weighting, and for the most part, there's gadolinium enhancement. Peripheral nerve tumors, you know what, we'll just keep going. The peripheral nerve tumors would be the schwannomas and the neurofibromas. These are generally round. They're less than 2 vertebral bodies in length, such as we're seeing here. And you may see widening of the neural foramen, low density or heterogeneous on CT. The sympathetic chain tumors, the ganglioneuromas, are fusiform, cover more than 2 vertebral bodies in length, and they're anterior to the vertebral bodies.